just about ready to start. We'll maybe give it a minute or so to give latecomers a wee chance to get in the room. I'll maybe run through some housekeeping just now while we're waiting. So I'll introduce myself first. My name is Gordon Hay. I'm Senior Improvement Advisor with HIS, and I'm the delivery lead for the Personality Disorder Improvement Programme. Apologies for that photograph. Nobody needs to see that at this time on a Monday afternoon. We will be hearing today from John Mitchell and Michaela Swales, who are going to be talking about issues around about diagnosis and formulation, with particular focus on ICD-11. We've got a slightly longer webinar today. I think there's a lot of stuff to cover within that, to unpack. So we're going to have an hour and a half today, and hopefully we can have a chance at the end for some question and answers. In any event, we'll be keeping track of all of the questions that's asked, and we'll email out responses to all of those after the event, but we'll try and get through as many as we can today. So we're going to keep cameras and mics off just to preserve as much bandwidth as we can. And I noticed that there's something like 164 people. We usually have about a couple of hundred people here, so there's a lot of people here, and it just allows the opportunity to maybe to minimise the chance of some of the glitches that we get on Teams. While I'm rabbiting on in the background, the team are putting up some of the housekeeping slides. So if people aren't familiar with Teams, the slide there can explain how to use things. There's a range of icons up the top of the screen that you can click on. Please use the chat function at the side to ask any questions that you want as we go through, or make any other kind of relevant points. So that's how that works. Can we have the next slide, please? As I'd mentioned in the chat, the webinar will be recorded, so we'll have, for people who are not able to attend today, or for people that maybe want to revisit it to look at a bit more of the detail again, that will be available. It will be on the HIS YouTube channel, and I'm not entirely sure when it'll go up, but that's where we keep them. I think the previous webinar events have been on there as well. This is now webinar 3. It seems strange to be saying. It doesn't seem that long ago since we launched this program. So the other events are on there as well. Next slide, please. So I've been doing the welcome and introduction section of this. So I think rather than me continuing to waffle on, I'm just going to introduce John Mitchell, who can probably introduce himself better than me, but I'm going to hand over to John, who will now do his section of the presentation. Thanks very much.
Thanks very much, Gordon. That's great. So I've got half an hour to speak, and I've actually got quite a lot of slides, so I hope you'll forgive me, but some of them I'm not going to just read them all out. I'm just going to kind of leave them for people as a resource should they want to look at them at some point in the future. But the story I want to tell you today is really what ICD-11 is, and really why I think it's important and actually quite exciting that Scotland is starting to implement this. And the story of ICD-11 will really be about all diagnosis, physical and mental, but then we're going to focus in a bit on mental health and how that's affected, and I'm going to tell you how Scotland has gone about the process of starting to implement this. And in the work that we did, it became very apparent that the lived experience aspects of this are really fundamentally important, and I'm going to explain why that is, and I think give a little bit more material on that to the end of my talk. So can I ask for the next slide, please? This really is the story of who I am. I'm currently employed part-time as mental health advisor with Scottish Government, and I'm the Scottish lead for the implementation of the International Classification of Diseases 11th edition, Mental, Behavioural and Neurodevelopmental chapter, which is a bit of a mouthful, but that's the acronym there. I got involved with this because I was Principal Medical Officer at Scottish Government for 6 years, and during that time I got asked by the World Health Organization to join the advisory group on the global implementation. And things got to a point a few years ago where it became apparent that really we were good to go, and I have stayed involved with that project since. And although it sounds quite a kind of dry and dull thing to be involved in a classification system rebrand, but actually the more I've got involved with it, the more important it has become aware. And again, I'll explain that in a minute. So anyway, could I have the next slide, please? When you want to get something done nationally, it's fundamentally important that you can get it into national policy. And the coronavirus recovery plan was an opportunity for a commitment, which was really to say that Scotland would move ahead with ICD-11 from spring 2021, and that really opened the door to us cracking on and getting on with it. And although some of the thinking about this is UK wide, because we have a devolved National Health Service, we've made the decision to move faster than England and implement this before England does. When ICD-10 came in, which many of you might remember, and when I was a trainee psychiatrist, I moved from 9 to 10. And then 10 to 11. It was actually a year before Scotland came in and joined ICD-10. So there is no reason the countries all have to do this at exactly the same time. Thanks. Next slide. So the 11th edition has been necessary because although the original remit with the WHO was that the classification system would be rebooted every 10 years, it's actually been 30 years since the last iteration. And as I'm sure you'll understand, concepts of disease evolve, both from a basic science point of view, but also from a social and cultural point of view. So the ICD-11 is free, it's open source, it's created and maintained by the World Health Organization's United Nations, and the web link is there for you should you want to have a look. And we need to remind ourselves that this covers all disease, physical, mental, and with additional codes for special purposes. And to do that, there are now 26 chapters of codes and diagnostic guidelines. And chapter 6 is the one I'm going to be talking about mostly today, which is mental, behavioural, neurodevelopmental disorders. Thank you. Next slide. So why should we actually have any kind of international classification of disease? Why is it important? Well, you've got to have globally agreed diagnostic standards. And that's because we have to be able to compare what happens in one country with another country. We have to be able to compare historically, time to time, and there are certain kind of core issues which I've laid out there that are really important. So the quantification of health needs, delivery and costs, morbidity, mortality is how we fundamentally that we know as a society whether the health of the nation is improving or not. We don't have an insurance-driven healthcare system in Scotland, but in countries where there is, the codification of disease is actually utterly fundamental to the costings and then reimbursements that then follow. There has to be clinical utility. It's got to be something that actually makes sense to the people who use this. And if we're going to do international research on anything, if we're going to compare a new treatment for a mental health condition, and we're going to be doing that as so often nowadays we have to internationally. We've got to be sure that we're comparing apples with apples. And I suppose a very simple example of that is, you know, if we're going to be doing, be sure that the vaccines for COVID-19 actually work, then what we call COVID-19 in Scotland today has to be comparable with the vaccine being used in the Philippines or in Canada or in New Zealand, and so of course there is now an ICD-11 code for COVID-19. And then teaching and education. Particularly in mental health, the precision of language is so fundamentally important that you know, we have to be very clear about the terms that we use, and the teaching of and education of people training to work in mental health really relies on a very precise clarity of meaning. So thank you. Next slide. I am delighted to say that this story doesn't start with a doctor. It starts with Florence Nightingale, who obviously was a nurse. And in 1860, she proposed a model of the systematic collection of hospital data, which was pretty revolutionary at its time. So she kept records and classified you know, the different sort of injuries that people were presenting with from battles and the other, you know, illnesses people had, and this allowed this allowed a kind of scientific approach to actually the provision of health and treatment at the time. And then Jacques Bertillon in 1893 brought in the rather attractively described classification of causes of death. And that led to an international classification of the causes of death. But then the WHO, when it was formed in 1948, assumed responsibility and for preparing and publishing every 10 years classification of disease. And ICD-10, which is what we currently use, was endorsed in 1990. So thank you very much. Next slide. This is a slide, I think, to hopefully comfort all of you, to show that this, why it's taken 30 years is it's not really just been a group of, you know, half a dozen, you know, middle-aged men in grey suits sitting in an office saying, "Aye, let's call this schizophrenia." That actually, you know, there's been a vast amount of work preparing, refining, checking, rechecking the constructs and creating them to be translatable. If you think about the challenge of making all of these concepts and constructs translatable to, you know, all of the major international languages in the world. So there's the timeline, and I'm not going to read it out to you, but you can see that you know, there's been, you know, field study upon field study, that there's been you know, two rounds of field trials in multiple countries, and I think one of the pleasures I've had in being part of the advisory group is that it's not the usual suspects. It's not, you know, America, Canada, Germany, United Kingdom, New Zealand. You know, it's actually China, India, Sri Lanka, Philippines. You know, it is truly a global network, and of course it has to be. The one thing I want to highlight to you is that from September 2020, WHO has been creating online training modules, and these are now finished, and they're really very, very good. They're very detailed, and they will be open to the public in the next few months. They're open to anybody if they join the Global Clinical Practice Network at the moment, who've been doing the pilot testing of those modules. But there is one specifically on personality disorder, so it takes you about an hour and a half to do. But that's the place if you're you know, got a very specialist interest to go and have a look. And then in the way that there's a website with the kind of all the codings, we've we've used up till now, I think we always called the Blue Book, which was the clinical description diagnostic guidelines that you had on a shelf and you take down, and it helps you think, you know, is this that condition or that condition. So this has now been finished, and for it's called the CDD-R rather than the CDD-G, but it's now up on the WHO website as well. So next slide, thank you very much. Michaela, after me, is going to give a lot more fine detail on really what's new and why it's new. And I'm just going to give very rough brushstrokes at the moment. But ICD-10 groupings were based on commonly presenting symptoms, and 11 is based on what is thought to be underlying causal factors. There are three aspects. The guidelines have got three aspects to them, which I quite like, actually. Essential features of a particular diagnosis, what the explicit threshold with normality would be, and what, if you like, the differential diagnosis would be, the differentiation between other conditions. And those are laid out, in the text to guide people when they're using ICD-11. And the other thing, which it'll be interesting to see when we use this in the real world, but it takes a lifespan approach, and it eliminates disorders occurring in children and adolescents. So, in other words, there isn't a sort of separate chapter on conditions for children and young people. Then the descriptions of how mood disorders manifest in children are included within the main, area on mood disorders, and it doesn't make a specific separation. Similarly, the conditions of old age, so things like the dementias, are not separated off in that way. And I think, talking to the child and adolescent psychiatrists, again, they quite like it, but it would be interesting to see this in the real world. And I think that ICD has always tried to include cultural considerations, but there is more specific comment about that in 11, about cultural considerations. So, next slide. Thank you very much. So there's the definition as the first bullet point of what the conditions are that are in the mental, behavioural, neurodevelopmental disorders chapter. There are some things that are out and some things that are in. So stress reaction, bereavement are now out of that mental health and are somewhere else. And sleep disorders are in neurology. Sexual dysfunctions, gendered incongruence are inside sexual health. And again, the feedback I've had from people is that certainly gender incongruence fits better inside the codification of sexual health rather than inside the codification of mental disorder. Next, please. That's a summary paper that is really long and really good and tells you all about it. Next slide. So I'm going to tell you about what Scotland's been doing and how we've been implementing this. So it'll come as no surprise that you do things really by group, and you have to bring together relevant stakeholders, and that's what we have done. And we've had now 4 meetings of an implementation group, and that group has made recommendations to the Minister of Mental Health, Mental Wellbeing and Social Care. And what his instruction to us has been is that he wanted a clinical transition to start from the 1st of November 2022. So that is coming up pretty soon. And so the Chief Medical Officer has written to all of the health providers in Scotland, the health boards and associated organisations, to say that and to ask people to start moving to 11, if they use 10, to move to 11 from the 1st of November. Interestingly, NHS Highland decided, but since they saw it in strategy, they decided on the 1st of January they would do this themselves. So the psychiatrists in NHS Highland have been using 11 in routine practice since the 1st of January, and they did an audit and a survey in May just to find out how things were going, and it seemed to be going fine. This, I should say that this is not a big bang. This is not a commandment that at midnight suddenly 10 stops and 11 starts for everything, and all copies of the Blue Book have to be burnt, and we all have to start with 11. This is understood to be a transition, and the Minister is I think very, very aware, as we all are, of the pressure on health and social care services, and the fact that really we have to recognise the fact that when we moved from 9 to 10, that we did this really in just a kind of experiential way, without a great big bang and great central commandments from government. So although government is pointing a direction and setting a line in the sand, this is, I think, being quite sort of intelligently done to allow a sensible transition. The minister also said two things, and I think these are really, really important, and this is where the implementation becomes really important and exciting, is that in this moment where people are moving from one system to another, there's an opportunity for us to think about the diagnostic experience, and I'm going to talk at length about that in a wee minute. And there's also an opportunity for us to improve the data that we've got in Scotland. Again, we're working on that. So next slide, please. Thanks. So there are lots of different work streams that we've been working on. The awareness and training quickly showed us that we need people have different needs. So for the interested general public, NHS Education Scotland have now created a short, I think it's about 4 minutes long, animation video to explain what ICD-11 is and what it isn't, and reassure people. And that will go live on the 1st of November. And alongside that, the Mental Welfare Commission Scotland are very kindly going to host an explanatory leaflet for the public with the other materials they provide. We thought we should have some bespoke Scottish training, and so again, NES are at the moment just creating an online training modules. Now, this isn't for doctors, this is for people who use ICD-10 in clinical practice, and so that we've written to boards and we've said that we would ask that people consider this to be part of their CPD, that we don't expect it to be a mandatory training module. And really the biggest expectation that we think of how people are going to learn how to use 10 to 11 is what happened with 9 to 10, and that's really just you picking the book up and looking up the codes and reading the stuff around it and experientially learning. So so the module will be available, I think, on the tourist website, and it's not going to, I think it'll generate a certificate, but it's not going to be something that people will be commanded to do, although we're hoping people will take the time to do it. And as I've said to you, we've got online modules for specialists, and one of those is personality disorders on WHO. And as you'd expect, there are new research tools, new standardised clinical interview schedules and things like that have been created. Next slide. So I told you data is really important. The WHO is seeking data now from January 2020 from all its member countries using ICD-11. The WHO has said on its website that this is an ask, it's not a demand, and that the recognised countries are going to be in different stages of development. And in Scotland, our data harvesting and analysis and reporting machine is Public Health Scotland, who are working with NHS Digital in England. Thank you. Next. And then if I take a deep breath, I'm just about to move on to the second half of my presentation. So again, one of our working streams was about lived experience, and we had a meeting with people with lived experience, and we're grateful to have two representatives on the stakeholder group. And we recognise the sensitivity of language is utterly fundamental, and also the aspiration about the diagnostic experience has come over loud and clear. So really, on the basis of that, we reached out through the WHO to work that had happened with lived experience. And I'm going to now tell you about the wonderful work that Dr. Karina Hackman has done. And if you could put up the next slide for me. This is a really unashamedly pinched from her slide set with her permission. So Dr. Karina Hackman is a psychologist by background. She works in Norfolk and in Norwich, and is a lecturer at University of East Anglia. And she's worked with Columbia University in New York and with the WHO. And I'm going to tell you about some of her research and how we are incorporating that into our Scottish story. So, thank you. Next slide. So, so there's three sections to her slides: the experience of getting a diagnosis, the content of diagnostic systems, and the process of diagnosis. So, next slide. Is the first section is really talking about her work on the experience of getting a diagnosis. So, next slide. So, you know, she's been leading a research program, and I'm going to talk about two major publications that she's done. But this is really on the basis of really, you know, years of work that she's been involved with, and she lays out here, I think, the positive aspects of receiving a diagnosis. And she makes, I think, the very important point that, you know, making a diagnosis can be viewed as a complex intervention, and, you know, viewing it that way means that we should consider both the intended and unintended outcomes of this. And certainly this is sort of fresh thinking for me. You know, I mean, as a psychiatrist, as a retired psychiatrist, you know, I hope that I thought about the impact and meaning of diagnosis with people and their families. But I think this really is quite a helpful way of thinking about this. And she lays out there, you know, the positive things that people have fed back, and a comment that has come from somebody with lived experience. For me, it actually meant something, explained something when I had the diagnosis. Although I was horrified, I was almost relieved, and now embrace the fact because I understand myself and my history a lot better. So the next slide is, as I'm sure you'll understand, you know, the negative aspects of this. It can feel reductive, labelizing, stigmatizing, meaningless. You know, when I was diagnosed at the age of 26, I was told not to tell anyone, never to tell anyone that I had this really severe mental illness, that I would never get work, that I had real trouble with relationships, and it was something to very much keep quiet about. So the stigma was intense, and I think we can all recognise that. Certainly, I'm old enough to remember, you know, that if you had a mental illness, you didn't tell anybody. When you were a doctor, you didn't tell anybody. And it's really only been in the last few years, you know, we've seen psychiatrists coming forward, and you know, and other people, you know, describing their experience. So. The point that she makes is both that the content of diagnostic systems, in other words, the creation of something like ICD-11, and the way that that's then used by clinicians and people using the ICD is decided and communicated. You know, we need to have lived experience perspective in that, and we'll be talking about that now. So next slide, please. And this is about the content of diagnostic systems, and bearing in mind the work that was done to create ICD-11. Thank you. Next slide. So this was the first big study I want to tell you about that her team was involved in. It's called the INCLUDE study, and it's in the Lancet Psychiatry. It's and the references is right at the end of the slide presentation. But in a word, simply said, as part of the work on ICD-11, what she did was she took the constructs and had group work with people in different countries and in different languages, thinking, what do you think about this? So there was feedback on 5 diagnoses: depressive episode, schizophrenia, bipolar 1, personality disorder, and generalized anxiety disorder. And they looked at the language that was intended to be used in ICD-11, but there was also accessible language versions created to have that. And so, you know, this was interesting work, because this was happening in other languages, not just in English. And so the comments that come out, I think, are really interesting. And if you show me the next slide, we'll start to look at the comments. So people people said you've missed things which are common and important to us. And, you know, as an example of that, they talked about interpersonal difficulties. And I'm going to keep moving on, if that's all right, to the next slide, just to get through these. And they said, the other one that people said was, there are things that you say that reflect outward appearance but don't resonate with lived experience. And an example of that is the proposed bipolar disorder type 1, which is kind of, you know, the mania hypomania construct, the decreased need for sleep. And what people said was they didn't sleep because they were thinking about other things, but they didn't feel less need for sleep, which was a subtly different, you know, it wasn't a decreased need for sleep, it was a decreased sleep. And people with schizophrenia said that you may think my thinking is disorganized, but it doesn't feel like that to me. So again, there was that sense of how it feels for people. And again, you know, that was the India focus group said what appears meaningless or disorganized to you may not be so for me. It can have a very clear meaning for me. And I think that's, again, an interesting perspective. Thank you. Next. And then, you know, there's the problem with language. You know, maladaptive is a word that, you know, people found, you know, unhelpful. I absolutely hate the word maladaptive. It's someone else's judgment if it's a bad adaptation or not, but it's an adaptation that somebody's had to make to survive the circumstances. So therefore, it's actually a valid adaptation for that person in that situation. That was the UK focus group said that. And you'll probably not be surprised to hear that the old psychiatric terms of, you know, retardation and neurovegetative states and depression was something that, again, people said, well, you know, these are terms that, you know, we don't like. Next slide. So, yeah, you know, so again, I mean, these are just examples, but the language was everything. And you'll be pleased to know that this material then fed into ICD-11. I mean, ICD-11 is predominantly a technical manual for clinicians, but all the same, it helped an awareness of this. So next slide. And then the next slide. Now, this is the second study I want to highlight, and I'm very excited by this. I call it lots of different things, and the current term I'm using with Karina is the rugby ball. Your beautiful rugby ball is what I'm calling this. So at the bottom, you'll see her description of a second publication that she did in 2018. Her team did a gigantic systematic review of literature on the experience of mental health diagnosis. And this was, it's a good paper to read, and this was an attempt to summarize everything that they found out into one diagram. And I'm hoping that this is going to get included inside the Scottish training and invite people to look at this. So if you have a look at it, if you can see it clearly, it is a whole series of questions, and the purpose of this is really to have this in front of anybody making a diagnosis, for them to actually think inside their head about, you know, what is the answer to these questions. And there isn't a right or a wrong answer. It is a tool to guide us through thinking about deciding the diagnosis there on the left, to communicating the diagnosis in the middle, in the right, and then using the diagnosis on the right hand side. On the right hand side. And you know, this is both from the perspective of, you know, delivering a diagnosis and, if you like, owning a diagnosis. And I wish I had more time, because what I'd like to do is really, you know, go make sure that you've got the time to read through these questions. In true kind of university academic styling, what the numbers are on the side is inside the key there. And it was a sense of, I think, of, if you like, the strength of how important that particular question was from the literature review that was done. So the darker the colour, the kind of more fundamental it felt from the literature that was there. And there's a key in the side for you to look at. I don't think that needs to get in the way of it. I think, you know, the simplifying thing is to think about that journey of deciding, communicating, and using, then the other axis of there are external factors at play and there are internal factors in the person at play, and really how we can think about this when we are in the process of this journey with somebody, this complex interaction, as Karina says in an earlier slide. So I hope you're as attracted to this as much as I am. Okay, we're almost there, guys. Next slide, please. This is again, just I suppose I'm so pleased with this. I really just want to kind of reinforce this model of deciding, sharing, and using the diagnosis, and thinking about again from a lived experience point of view. Is my expertise in terms of my history and experience valued? I want information and support to help me make a sense of my diagnosis, and I want to be involved in thinking about how the diagnosis is now used to make treatment decisions. And that's again that journey from a lived experience point of view. And then the next slide. And then this was a sort of, this is the gap, the chasm between clinicians and patients, and this is how we build a bridge across it. So we've got the bad clinicians, which I hope I wasn't in the olden days, but at the far end, not disclosing a diagnosis, impersonally informing, doing it face to face, then actually having some limited inclusion and assessment, to properly including people, to being open and flexible and collaborative in deciding this, and actually sharing this decision making and learning. And then if you click on again, you'll see a nice quote at the bottom. Thank you. So I think the way your diagnosis is delivered is really important, because it can be delivered in a way which is helpful, which helps you make sense of things, that helps you understand it, can promote personal recovery, and it can be a relatively positive thing. But when I got my diagnosis of emotionally unstable personality disorder, I was told, ooh, you're not going to like it. This is a really bad diagnosis. And I thought, brilliant, there's something really wrong with me. And it was like, well, where do I go with this from here? Obviously I'm defective. So again, there's kind of a mixed feeling in there, isn't there? And you can almost understand that situation and think about that getting a diagnosis. That there is an opportunity to think about, okay, where do I go from here now with this, and to help us, I suppose, bridge this chasm. Thank you. Next slide. There are the references. I'm not sure if these slides are going to be made available, but there's no problem should people want them to. But those are the references for those papers. And my next slide is simply, thank you. The next slide is simply a beautiful image of Edinburgh from the castle, to say thank you for inviting me today, and just give you my email address at Scottish Government at the moment. And I hope I haven't gone over my time, maybe by a couple of minutes, but Michaela, please forgive me, and thank everybody, and I'll have a look at your questions and try and do my best after we've heard the second presentation. Thanks.
Thanks very much, John. That was extremely interesting. Some really useful stuff in there, and lots of food for thought. We'll move swiftly on. And Michaela, if you're ready, I'd like to invite you to take control of the slides. And thank you very much.
Yeah, I've somehow managed to advance to both at once, but never mind. I'm on the main point here. Anyway, thank you very much for inviting me. I'm Michaela Swales. I'm a clinical psychologist by background. I, like John, have conflicts of interest. I receive income from training in DBT, which many of you all know is a treatment for certain forms of personality difficulty, consultation supervision in DBT, and also royalties from books in DBT. My husband is the managing director and principal shareholder of British Isles DBT Training, which is that trains in that treatment. And then I was a member of the ICD-11 working group for personality disorder diagnoses. And also I was reminded when John was talking that I was involved in writing some of those training packages that he mentioned. I think it's important to say that the reason I was invited to be on that ICD-11 working group was primarily because my clinical expertise at the time and for most of my career has actually been working with young people and adolescents, and in particular thinking about the impact of the changes in the diagnostic guidelines for younger people. And in this presentation, I'm going to talk a bit about personality and personality disorder and about the changes. I was also asked to say a little bit about the interface with complex PTSD and also about formulation. And so that's what I'm hopefully going to do. Although it's fair to say that I'm mainly focusing on the changes in ICD-11 and touching on the other things as we go through. Okay, so I want to say something about the context of personality disorder diagnosis. To me, it's different to diagnosing anything else, and that's because we all have a personality and it's central to how we describe ourselves. And there's actually a risk of harm from the diagnosis. I mean, I think one could say that from any diagnosis potentially, but I think the risk of harm is particularly high with this diagnosis. And so it's really important to proceed with caution. And I think one of the particular reasons is, I mean, John has covered it beautifully in that presentation and the wonderful work there that's been done on this, is the issue of stigma. And we know actually from the data that where service users typically tell us they get the most stigma is actually from mental health professionals. And so it's especially incumbent upon us to, as we're thinking about these conversations, to think about how might we do this in a way that is helpful and not in any way stigmatizing. So there are some potential harms because of stigma. And yet on the other side, so you could even say, okay, you know, and I know some people would say, why didn't we just get rid of that diagnosis altogether? You know, because of the risk and the various issues with it. On the other side, though, there are now effective treatments for people who have the sorts of problems that get labelled as personality disorder. We know that people who have those labels, sometimes their outcomes in other treatments are not as good as they would be if they didn't have those difficulties. And also that the unfortunate thing is, whilst in a way, personally, I wished I lived in a world in which a diagnosis or a diagnostic system was not necessary in order to advance research. Unfortunately, we're still in a system where actually it's really hard to get research done on problems that people are experiencing without some kind of classification system. And so we haven't got all that, we wouldn't have had all of the research that we've had on these types of problems if we hadn't have had a diagnostic system. So there are different costs benefits, I think. However, we still need to proceed with caution. So I just wanted to say something about personality development generally. So personality, for all of us, it's a mix of our genetics and also our experience. So no surprises there. It's important to know, though, that genetics does contribute about 50% towards our personality traits and our early temperament. But of course, what we know now increasingly is the impact of early development, trauma, adverse childhood experiences, and that these things interact with our genetic heritage to either, you know, shape a more helpful developmental trajectory or lead to a development of a more troubled developmental trajectory. And as John was saying, really, our personality is really learned patterns of behavior, which is how we cope with the environments that we are in and how we respond and how we internally react and feel about those experiences. And as we mentioned, you know, that our personality, whether or not we end up with a diagnosis of something or not, is our best effort to cope with our past history and our genetic heritage. And it's always important as a professional working with people is that behaviors and patterns and experiences that a person has learned as a result of their history are entirely understandable reactions and often functional. This is one of the things I often talk about with the people I work with, is that the way they respond and react is often highly functional in what I would say a very dysfunctional environment. And at the same time, those patterns and responses are also causing a lot of distress and pain and difficulty. And this is the real challenge, that we have to embrace both of these things. And as we're having these sort of discussions with our clients, we have to really think about how those patterns have developed and how they totally made sense in the histories of the people that we're working with. As John's touched on, and I think that's kind of the background context in which to have any of these discussions about this diagnosis with people that we work with, is to understand where and how their particular patterns, their particular ways of interacting with both others, but also with their inner selves, where has that come from? How can that be made sense of? And then crucially, of course, how might we move to try and help a person to change those things that they want to change? So the main changes from ICD-10, and if you think about ICD-10, it was a categorical approach. There were 10 different personality disorder diagnoses, and each one of those had a long list of features that a person had to have. And this led to what we would call an artificial comorbidity, because there were lots of overlap between these different categories. And so it meant that actually people would accumulate lots of different diagnoses without really meaning anything. And so that was a major problem. The other thing that was problematic about it is if you looked at the data from across the world, in practice, only 3 diagnoses were used with any degree of frequency. Emotionally unstable personality disorder, personality disorder not otherwise specified, and antisocial personality disorder, and that was much less than the other 2. So it also was not a very useful classification, because there were all of these different categories and actually they weren't really being used. So ICD-11 really wanted to make a big change there, and I think John touched on this. One of the reasons also for this, it's really important to consider, and it was something myself, coming from a wealthy Western country, I hadn't really thought about until I met with the other colleagues on the working group, looking at this, where, there was one of my colleagues, David Ndete from Kenya, was the single psychiatrist for the whole of Kenya at that time. Another colleague from the South Sea Islands was, there was only one clinic once every 3 months when he was seeing people. From someone with a mental health qualification. And so in those contexts, you need a different kind of classification, not just for personality disorder, but for everything, something that's much simpler and much more straightforward, and something that can be used without formal measurement and assessment. I will touch on that because I've seen a question in the chat about that, but it's important to bear that in mind as the context. Also, the ICD-11 was informed by a range of research that shows, that it actually, these different kind of diagnostic entities, as we might call them, which were sort of prototypes that people would describe, actually don't really hang together if you look at them from a scientific perspective. So ICD-11 moved to a single category of personality disorder. So in that sense, it's still categorical. You either have a personality disorder or you don't. But instead of these different kind of types, we might say, what you do is you rate the severity of the personality problems. And severity is strongly related. It's the best predictor of clinical outcomes. And in low resource settings, that's probably all you would do, is decide, is there a personality disorder present or not? And if so, how severe it is. Those 2 things are the required elements. But then in more developed countries and more complex, and I think this is one of the things often we're wanting in our system, you can then proceed to identify trait domains. And so I'm going to just say a little bit about each of these. So the first step, oh yeah, I've just said that. So that's the kind of the steps of making the diagnosis. Assess the general PD diagnostic requirements, If they're met, assess for severity, and you can stop right there. You can then, if you wish, go on to assess personality trait domains, and if applicable, assign a borderline qualifier. So I'm going to cover all of those. So the general PD diagnostic guidelines, you have to have had enduring problems for over 2 years, characterized by problems in functioning of aspects of the self and or interpersonal dysfunction across various contexts and relationships. And this is whichever diagnostic, whether you have ICD-11 or DSM-5, these two things of functioning in one's sense of oneself, which is often what we think of as our personality, and how that also links to our interpersonal relationships is kind of central. This is manifested in this awful word. I have to say, we did agonize about the word, and clearly we have failed our service users by using this word, in maladaptive patterns of cognition, emotional experience, emotional expression, and behavior, because it's true, these patterns are adaptive in some contexts, and they are also problematic in others. And somehow we haven't managed to get that the balance right there. But I think this is the important thing about when working with people, is to be sensitive about the language here. The disturbance is manifest across a range of personal and social situations. So it has to be in lots of different contexts. It has to be not developmentally appropriate. So, if we think about interpersonal, not knowing what you think, what you believe, what your passions are, having somewhat sort of intense interpersonal relationships. Some of this is quite normative in adolescence. And so you want to be really clear, if you're thinking about this with young people, that what you're seeing is really significantly outside of what's typical. It's not explained, what you're seeing. These patterns are not seen, can't be explained by social or cultural factors, including socio-political conflict. This is really important, just thinking about, certain places in which psychiatric classification can be used as a means of social control. I mean, some people would say we do that in this country. That's another debate, but we do have to really think about this. And I think this is really important if you are assessing someone who comes from a different cultural heritage to your own, that you really need to be thinking about, am I imposing some kind of view about what I think is acceptable, appropriate, out of the ordinary here? Not due to the direct effects of a medication or a substance, including withdrawal effects. And it has to be associated with substantial distress or significant impairment in personal, family, social, educational, occupational, other important areas of functioning. And you'd be wanting to see that in several areas to even be thinking about it. Okay, so you have, if you're going to make the diagnosis, you have to assess whether those criteria are met. And obviously in the full criteria, there's more details about those different things. There is then an imposition of this kind of dimensional construct, but in essence, because in the ICD-11, you have to make a code, it ends up being a category, but of mild, moderate, or severe personality disorder are the ones in the disorder categories, and then no personality pathology or personality difficulty is below threshold for making the diagnosis. So how do we determine severity of personality disorder? Well, it's determined by the following: the degree and pervasiveness of disturbance in the person's relationships and their sense of self, the intensity and breadth of the emotional, cognitive, and behavioral manifestations of the personality dysfunction, the extent to which these patterns and problems cause distress or psychosocial impairment, and the level of risk of harm to self and others. This is a brief summary of what mild personality disorder might be. So not all areas of personality are affected. So you have to see it across several areas, but maybe not all areas. Some relationships are maintained, some roles carried out. The person might have a job, they might be married, they might have some social part of some kind of social network, but maybe there are problems with other aspects of their life. The problems in emotions, cognition, and behaviour are generally of mild severity, not associated with substantial harm to self or others. It may still cause substantial distress and impairment. So the distress and impairment is limited to a narrow range of functioning, or if the difficulties are across many areas, the difficulties are generally less intense. And I think that there's a real problem when, again, we agonized over this term mild. You know, if someone has some of these difficulties, they may well not say it is mild. But they still, because in order to meet the criteria for personality disorder diagnosis, it has to be causing substantial distress. Yeah. And so this is one thing we have to be careful of. Even if someone is labeled as mild, that does not mean that there's not significant distress for that individual. Moderate, I mean, as you would expect now, what we see, much more areas of personality are affected. Marked problems in most interpersonal relationships. Expected social and occupational roles are impaired to a degree. Relationships are characterized by conflict, avoidance, withdrawal, and/or extreme dependency. And the thing is, we'll talk about the different ways in which a person might have these difficulties, because that really depends on the trait domains that are relevant to them. The cognitions, behaviors, and emotions are generally of more moderate severity. It's sometimes associated with harm to self or others, and a marked impairment in important areas of functioning. Although in circumscribed areas, the person may still be functioning quite well. I run a program at the University Wellbeing Service for students who have severe difficulties, and some of them would definitely meet criteria for a personality disorder diagnosis. We don't actually diagnose in our service, but they would do. But they are still at university. And so their educational functioning is relatively well preserved, even though many other areas of their life are significantly affected. Severe personality disorder, this is where you see severe disturbances in the functioning of the self. Virtually all relationships are affected. The ability and willingness to perform expected social and occupational roles is absent or severely compromised. Emotions, behaviours, and cognitions are extreme. It's often associated with harm to self or others, and with severe impairment in nearly all aspects of life. So, as I said, there are further descriptions in the criteria about making these distinctions, and also there are now developing measures where one could, issue a kind of measure and try and get a more accurate sense of how many, where on this continuum a person might be. Personality difficulty is not considered a mental disorder. It's actually rated in another part of the classification. It refers to personality characteristics that might affect treatment with health services, and again, long-standing difficulties. But it typically relates to how a person engages with healthcare services, and so it doesn't meet the criteria for diagnosis. And I think many young people might actually end up with this sort of, it's kind of, there are problems, they're systematic, but in their engagement is difficult. And it's a way of just making sure we don't lose the impact in thinking about how a person's personality impacts on their engagement with services. Okay, so the intended advantages of this simplified approach is it's much simpler to implement. I mean, of course, now it's new to you. If you're new to the other, you're kind of thinking, oh, goodness me, this seems terribly complicated. But actually, once you get into it, it's much simpler in terms of you simply have to, do they meet the criteria for personality disorder, and what severity is it? And potentially, it has much greater clinical utility, and some of the work done on the field trials demonstrates that actually clinicians do find it easier to use. It also, the severity classification can be used in more non-specialist settings. It's much easier to utilise, and that could potentially be really helpful. Where some of the people that we work with, perhaps there's a lack of understanding of some of that aspect of their difficulties, and it's not really understood so much. It potentially improves the identification of risk by making it a focus of part of the classification. It also improves the differentiation of need for complex versus simpler treatments, and some colleagues have started to do a bit of work on this, and I'll touch on this a little bit later. It also helps to track change in personality status over time. And I think this is really important, is that our personality changes with time. And that also means that people who get labelled as having a personality disorder, that can also change. It can become less severe, more severe. They come out of having the label altogether. And we really want to kind of get that across, that this is not a kind of one-time deal. It's not something fixed about a person. In fact, the data seem to show that actually for some forms of personality challenges, those things improve with time, and especially if we give people the right kind of support and intervention. So, as I said, you can stop right there if you're thinking about personality disorder. You don't have to go any further. But I think often in our cultural context, when we have got more affluent context, we might say, oh, I know none of us are feeling affluent in the current context, but relative to people in Africa and other countries with very limited mental health resources, defining whether or not a person has personality disorder issues and the severity would probably not be considered sufficient. So what you can then do is go on to describe the person's difficulties in a collaborative manner by talking with the person about how they experience these things, using the trait domains. Now, trait domains are continuous with personality characteristics in individuals who don't have personality disorder. We all have them. This is a ubiquitous, this is about being human. And, in a way, thinking about what I was talking about before is that some people, because of their life experiences, unfortunately, the way their traits are now in the context, there's a mismatch, and it's therefore really hard for them because the environment they're in is not helping them with the sort of history that they've had. So these are not diagnostic categories. They're a set of dimensions that correspond to the structure of personality. And you can use as many trait domain qualifiers to describe personality functioning as you wish. And, in discussion with the person that you're talking with, what seems to fit for them? What do they identify with? What can they say is an issue that is for them? So individuals with more severe personality disturbance, so those who are more likely to get severe personality disorder diagnosis, tend to have a greater number of prominent trait domains. So you tend to be able to endorse more of those. And a person might have only one prominent trait domain also. Yeah, so it's not a guarantee. It's simply with the person, talking it through and figuring out what works or what's the best description for them. So these are the 5, and partly because they are in research that, they don't necessarily have particularly friendly names. So negative affectivity, detachment, dissociality, disinhibition, and anancastia, which is perhaps the most obscure. Psychoticism or schizotypy, as it sometimes can be referred to, isn't included as it is in DSM-5, section 3. And that's because schizotypal disorder in ICD-11 is classed in schizophrenia and other primary psychotic disorders. And I think this is also one of the other things I wanted just to orient you to, is that the ICD-11, as John was saying, is this a huge task. It's like a huge tanker that they're trying to steer. And we were very aware that there were some things that we were talking about that touched on other categories, and there wasn't anything that we could do about that, and this was one of them. There was no way that we could bring that into personality disorder because of something to do with structure of the classification, which I'm not sure I totally followed, to be honest. But so that's why you don't see that here. So trait domain qualifiers describe a profile of personality. And as I said, we all have them. And this is one of my hopes for this, is in having this sort of conversation with a person, when we're trying to really destigmatize these issues that come up, is to really make this connection back with everyone's personality. We all lie somewhere on these domains. And it's about that conversation. So in this particular case, this would be a person who was low on negative affectivity, but high on detachment and dissociality, low on disinhibition, and low on anancastia. Yeah, and I'll tell you a bit about these different ones for the ones you might not be so familiar with. So negative affectivity, this is perhaps the most common, and of course you see negative affectivity, of course, across lots of other psychiatric diagnoses, and that's because it's a trait that we all have, you know, high or low on this particular way of being. And the core feature is this experiencing a broad range of negative emotions, with a frequency and an intensity that is often judged by others to be out of proportion to the circumstances. Although, as we all know, if you actually talk to the people who are coming to us for help, is that it often makes a great deal of sense in the context in which they're living, or indeed in the result of their history. They might have very frequent mood shifts, difficulties regulating their emotion, it taking longer for emotions to come back to baseline, lots of negative thoughts, hopelessness, worthlessness, often low self-esteem and self-confidence, and they may also be mistrustful of others. Detachment, the core feature here is maintaining interpersonal distance, which is known as social detachment, and emotional distance, emotional detachment. So social detachment is avoidance of social interactions, and often what the person themselves might describe as unnecessary social contact. You know, to them, social contact doesn't seem to be necessary. They may actively discourage social interaction. They often lack friends and acquaintances, and they often avoid intimacy, including sexual intimacy. And at the same time, they also feel acutely lonely. Emotional detachment is where the person often has a very reserved, or some might say a kind of aloof or distant manner, often limited expression, both on the face and also verbally. And they may report, when you ask about this, a lack of emotional experiencing altogether. However, I think it's really important not to assume, simply because of a person's presentation, that that is their inner experience. As we heard from before, that's a real problem, where, you know, just to make that assumption that because the person isn't necessarily signaling emotion, that they're not experiencing it. And, you know, there can be people who are very high on negative affectivity, so they have a lot of internal expression of emotion, but don't express it for various reasons. And so that's always an important conversation to have. Dissociality, the core feature here is disregard for the rights and feelings of others, encompassing both self-centeredness and a lack of empathy. The people might have a sense of entitlement, expect others to admire them. They often feel a real strong need to be at the center of other people's attention, and struggle to take on board other people's needs and desires, and are really sort of focused on their own. There's often a real kind of problem here with lack of empathy for others. You know, they might be unconcerned about the feelings of others, even though they cognitively understand them, but they're just not able to, or don't feel a concern about it. They may exploit people for their own ends. And at the extreme, and I am talking about the extreme, there might be a callousness about the suffering of others. Yeah. So that's dissociality. Then disinhibition. So the core feature here is a tendency for impulsive action in response to immediate internal or environmental stimuli without considering longer term consequences. So I think kind of it says exactly what it says on the tin, you know, but so there's a difficulty in delaying reward and satisfaction. Often people high on this trait might be quite distractible, or might become bored or frustrated. They might find it hard to follow through on their commitments, and they perhaps struggle with planning and prefer more spontaneous ways of being in the world. And then anancastia, as I said, this is the one that's sort of perhaps, you know, the most odd phrase. It's not the one that you could kind of so easily see kind of connected to functioning, but this is a narrow focus on a rigid standard of perfection, of right and wrong, controlling one's own and others' behaviour in situations to ensure conformity with these standards. So so there's a strong emphasis on rule following, doing things really accurately, preoccupation with social rules and social processes, high intensity, focus on detail. And this is one of the things, you know, you can see about in these traits is that, you know, that some of these things can be really useful, yeah, and really important, you know, and all of these things can be a help and an aid to all of us in functioning at different times. But it's like all of these things, when there's just too much or it's too extreme, or there's an inability to be flexible with your typical trait, then that's when the problems kind of arise for a person. Okay, so just aware of the time. So, oh yeah, I want to say about the borderline pattern qualifier. So this was included to enhance clinical utility and continuity. I mean, we really wanted to remove it altogether because it's an old label for something that's really not well specified. There's a lot of overlap with the information contained in the trait domain qualifiers. And also, if you do a factor analysis of personality disorder traits, borderline personality disorder doesn't fall out as a thing. It's not a coherent thing. Actually, what it more looks like is it's a sort of, it represents moderate to severe personality dysfunction, is what it is. So it loads across all of these different factors, and it's a marker of severity. So we did really want to kind of remove it altogether. However, there's been a lot of research in this field. There are treatments which have good evidence for them. And as John pointed out, in some jurisdictions, you cannot get access to any treatment if you don't have the diagnosis. And that was the last thing we wanted to do, was to result in people who are already marginalized, disadvantaged, don't get good care, to, you know, start to not be given some of the things that have finally come along that really have been helpful. So we retained it so that it still can be used, but it comes right at the end. The encouragement is to use the trait domain specifiers, qualifiers rather, before doing this. And because it was just, it looks like the same DSM-4 criteria and similar to what's still in there, DSM-5. So there's no change there, because the whole point was to keep connection with the past. Okay, so in working with people who come whose presentation might lead us to think that personality disorder is a label that might be relevant, we've really got to be awake to social and cultural contextual factors. We've really got to consider the costs and benefits, and in particular, the most important thing is this point of seeing and understanding that this is the person's best efforts to function in the environment they're in currently, given all the things that have happened to them. You know, that phrase, what has happened to you? This is a really important question. What has happened to you that has impacted on how you navigate both your sense of yourself and your relationships in the world? But when you've had those kind of conversations, you're having that conversation, then the steps are to assess the general PD requirements, assess the severity, and then look at the personality trait domains relevant to the individual and to talk through that with them. Okay, so I was asked to address this issue about complex PTSD. So, so this is where the point I made about the different parts of the classification is that complex PTSD was being dealt with another group, which was to do with trauma. Now, we did have someone who was on our group and who was also on that group, you know, who from WHO, who went across. But, you know, so there wasn't an opportunity to suddenly have the conversation about, well, if we have complex PTSD, do we even need personality disorder, or like, how does that go? So I'm just kind of, this is where the situation is at the moment. So complex PTSD develops following exposure to an event or series of events of an extremely threatening or horrific nature, most commonly prolonged or repetitive events from which escape is difficult or impossible. And you can see some examples there, and some of which, of course, are the repeated childhood sexual and physical abuse, which we know are some of those kind of that adversity in early childhood, which can drive some of the things that now end up being labelled as personality disorder. So to get a diagnosis for PTSD, you have to have for complex PTSD, you have to have all the requirements of PTSD. So you have to be re-experiencing the trauma, you have to be avoiding thoughts and memories of the event, and you have to have perception of heightened current threat. And then in addition, You have to have these persistent disturbances in self-organization, problems in affect regulation, beliefs about yourself as diminished, defeated, or worthless, accompanied by feelings of shame and guilt or failure, and difficulties in sustaining relationships and in feeling close to others. And these have to cause significant distress, as they would. And you can clearly see that these overlap with the old borderline pattern. Yeah. And, you know, with some of the features I've just been talking about. So what are some of the differences? This is really helpful work that's being done by Felding, Nicholson and Barth. There are some differences in symptom duration and some differences in self-functioning, some differences in interpersonal functioning. Generally speaking, within complex post-traumatic stress disorder, there are narrower definitions about the kinds of beliefs and emotions that are more specific to the stressor of the trauma, whereas in personality disorder, it's broader and more about stability and sense of coherence of the sense of self. And in complex PTSD, the difficulties in sustaining relationships and feeling close are more toward the avoidant end, that whereas in personality disorder, there's more a sense of it being broader and the difficulty in understanding and appreciating others' perspectives. So there are some differences here. I mean, do I think it would have been helpful to have thought about this in a slightly different way and work? Yes, I do. And I also recognize the challenge that this wasn't possible. So what to do? Handling the diagnostic overlap. Again, Felding and colleagues have done a really good job here, just in summarizing and explaining what happens and what's the boundary section between where one disorder ends and another begins. And complex PTSD allows for the allocation of a personality disorder diagnosis in addition if it provides clinical utility, in other words, access to a specific treatment. So, but personality disorder guidelines explicitly state only diagnose personality disorder if the person's problems are not better described by another diagnosis. So if the person's problems are much better described by complex PTSD and that describes it, then you do not need to go to personality disorder. You stick with complex PTSD. However, if it would be helpful in some way that they might get access to additional services or additional treatments that you and the person together you think would be helpful to them. Now, in our country, you probably can do that without giving them another label. But in some countries, you can only do that if they got another label. You can do that. So just in summary, you know, early childhood experiences shape our personality, and persistent early childhood adversity may result in complex PTSD, personality disorder, or both. Yeah. Although they're not really two distinct things, I would argue. You know, kind of, you know, what we're talking about here is how people have learned to cope with the stuff that's happened to them, essentially. And we're trying to, you know, kind of essentially putting labels on to try and help people find the right kinds of treatments. Not everyone with problems that are labelled as personality disorder has a trauma history. And I think that's really important to bear in mind. And it's important that those people don't get left behind, because I think with the strong focus on trauma, which is right and proper, and I really want us to embrace, it can, I've had young people, adults come to me say, I feel a fraud because I don't have a trauma, and yet I have all these difficulties. And it's really important that those people don't like feel that somehow they're left behind. Whatever labels you decide with your person you're working with, describing and understanding these patterns and where they come from with the people who come to us for help has got to be the starting point. And then from that, choosing treatments with an evidence base that accounts for personality issues, if that's relevant. And for people who have, you know, the broader spectrum, so they do have complex PTSD and they do have extensive other personality issues. You know, people who have some of these personality difficulties and challenges are more likely to end up traumatized. You know, they're more likely in contexts where they're going to have further traumas happen to them. So they may have had the personality issues before their trauma and then they get complex PTSD. We need to think about treatments that can really address both of those things. And this is a real challenge going forward to really get into that and to work what works best for the people who come to us. Okay, so that's it. Sorry, I think I just took the extra few minutes that John took. So I hope that's okay.
That's absolutely fine. You can have those couple of minutes for free, Michaela. Thanks very much.
Yeah.
That was excellent. There's so much detail. There was so many important themes been highlighted within both of those presentations. I'm conscious we've had quite a few questions in the chat while we've been progressing. I'm going to ask people to do a wee bit of multitasking just now. So John's going to answer some of the questions that come in when he was talking. We've kind of ranked them based on the amount of likes that they got, so that we've got some kind of idea of which ones are carrying most interest. Every question will be answered, and we will send out the Q&As to everyone on the call after the event. While that's happening, there's going to be a kind of evaluation poll popping up in the chat anytime now, and if people could just complete those polls while John's speaking. I hope that's not going to be too distracting for people. But over to you, John.
Great, thanks very much. Thanks everybody for the questions. It's absolutely fantastic to see that kind of interactivity while we're presenting. I'm aware of time's pushing on, so I'm going to rattle through them and just answer them as briefly as I can, if that's okay. And I've got the list here. I'm just going to go down it as it comes. I think it was Jeremy D asked, how would ICD-11 be integrated in the Scottish Mental Health Act? Interesting question. Part of the work we did was about legislation, because I was aware that the current Mental Health Act excludes certain diagnostic categories. So, for example, alcohol dependence is explicitly excluded. So I thought it was a big deal. We went to the lawyers and they weren't at all troubled about the current use of the law. They didn't see us getting in the way. And in terms of future-proofing the legislation, because I think people will understand that, again, a lot of the lived experience feedback we had was a great discomfort about the fact that currently learning disability and personality disorder is included in the Mental Health Act, and the future plans for legislation are reconsidering all of that. So the Scott Review is currently considering and going to make recommendations about a fundamental reboot of mental health capacity and support protection legislation. So really, essentially, we communicated with the Scott Review and told them that ICD-11 is coming in and it's a thing, but it is fundamentally up to it to decide what recommendations it makes for future legislation. So sorry, that's a bit long-winded, but at the moment it doesn't cause a problem, and in the future the Scott Review will consider it in their report. Okay, the next one I've got is about purchasing copies. Yeah, well, as I said, my old job, I reached for the blue book quite commonly, but actually everything's digital now, and the WHO majored on the fact that they were making everything digital. And although the CDDR has now been written, I don't think there are any plans for it to be a physical book. So instead, what the WHO is working on at the moment is actually a relatively simple to use app for people's phones, computers and tablets that will help really with the background explanatory material for the codes and constructs. If you've not had a wee rummage on ICD-11 yet, please do that. I saw the web link is in the web chat, and it is the whole of physical and mental health laid out. You tap on the one for mental health behavioural, there's a sub menu, you tap on the one you're interested, there's a sub menu, and stuff comes up in a box on the side. And I'm hoping that actually in the clinical world that will be enough. Somewhat daunting for old dogs like me, but for younger people, I think tapping on icons is how people are used to using. So we'll certainly need to write to boards again and make sure that people are aware of these resources. And I think if they do become published, well, then it's up to the boards to decide if they're going to purchase them or not. It will be their responsibility to make sure that the staff are equipped to be able to do their job in this respect. Okay, right, here we go. So that's Blue Book. Blue Book, yep. Now, there's quite a technical question here about, from Richard T. Bach et al., difficulties in conceptualizing new concepts in the PD dimension trait descriptors, collision user interface documents, like the DSM-5 AMPD. Is there going to be a subgroup looking at operating scales questionnaires? Not in Scotland at the moment. There won't be, but certainly I know internationally, the Columbia University in New York are leading for the WHO research work on personality disorder. Now that actually the ICD-11's been published. I mean, we're going to talk about, I suppose, DSM ICD later, and I think someone else came in and asked about that. That Francis T had asked about the main differences with DSM. I mean, DSM fundamentally is a product of the American Psychiatric Association. It is, you know, the final analysis, you know, only created by them and only a product meant for the American Psychiatric Association, whereas ICD is an international, global, currently 194 signed up countries, and that's that. So I don't trouble myself with DSM very much, and I hope that doesn't sound terribly naive, but you know, it's ICD is I think the main game in town, and that's the one I think that we should be focusing on. And I think if specialist tools need to be created, they should be created under ICD rather than DSM. And that, I think that's really all I've got to say. I mean, I think we're all hoping that maybe ICD-12 and DSM-6 will be exactly the same thing. And I know there's been a lot of cross chats between 11 and 5 to try and kind of get some agreement around some of the constructs, but it is unhelpful, really. I mean, it's unhelpful. I think there are different categorizations, and
can I just come in on that?
Yeah, please.
I think with respect to personality disorder, the main differences are that DSM-5 wanted to go the way ICD-11 did, but kind of backed off under pressure. So DSM-5 still has those old categorical diagnoses, but they put their new categorization in the appendix. And actually, there's been a lot more research on that now, and a lot more people are using it. And the main difference is that they have a severity element also. But what they do is they go down to what's called the facet level. So we've got the trait domain qualifiers like negative affectivity, and underneath that there are various facets, which I mentioned, you know, sort of like worthlessness, emotional lability. So they burrow down a little bit, which is kind of what you can do in an advanced healthcare system. But I'm with John. I think that we, you know, in the thing to do is to really embrace ICD-11 and try and really move forward with that too. Unless you're working in a research context, in which case many journals will require your, you know, your DSM-5 coding. You know, but, yeah.
Thanks, Michaela. I was going to pass over to you. The only other comment I was going to make was further down in the questions, which I think were coming in during your presentation. There was a comment about, is there a sort of gender-specific thinking about ADHD? And, you know, yes, there is. So if you have a look at the ADHD criteria, you'll see a specific section recognizing the, you know, there's a difference prevalence in symptom manifestation between genders. So can I pass over to you, Michaela? I think that's...
Yeah, no, absolutely. Yeah, no, that's fine. So yeah, just moving down there. Yeah, Laura, you were asking about why weren't the other categories not used in ICD-10. I don't know of any specific research on that, but I think it was probably to do with the difficulty of retaining all of these different kinds of, you know, criteria in order to make that change. Dwayna, I'm not sure if I'm pronouncing your name correctly. I'm sincere apologies, Dwayna Affleck. This is a really important point, that the whole emphasis, the whole structure of classification is based on a white Western sort of way of thinking about mental health. And I think that really is a problem. And whilst on all of the groups, there were people from other countries, other cultures, more sort of collectivist cultures, who clearly would conceptualize these things very differently. On often I think there's a sort of, dare I say, that sort of cultural imperialism of these ideas. And so I think this is a major issue to grapple with. And I do think when we're talking with people who come from cultures that are very different to our own and that we don't know, we have to tread very carefully in trying to understand these things. So I'm not sure that I've answered your point, but just to kind of validate the real importance of that point that you're making. Oh, what does the implementation of ICD-11 in relation to the personality disorder mean for the IPDE, the assessment instrument? There's actually some really interesting work done. But Bo Bach, who one of the other colleagues was mentioning, Richard Taylor, I think was mentioning, Bo Bach, as one of my colleagues in the ESSPD, has done a tremendous amount of work on all of these different assessment instruments. And there's also some new assessments coming out, which will allow you to assess for both DSM-5 and also ICD-11. So, and how you can use the existing measures to derive the categories. So, watch the space, really. There's more of stuff coming out about that. Yeah, the severity indicator. There are ongoing work about the severity indicators and how to do that. There's a new measure out by Leanna Clark, who was on both the DSM-5 committee and also the ICD-11 committee, and she's developed a new measure, which she's got some data for looking at that. But there are some briefer measures coming out. Okay, Eleanor, I'm aware we're up for time, but so we might have, do we have to stop? Or should I just keep talking fast?
Talk fast.
Talk fast, okay. Eleanor, yeah, I think this is an interesting point about, will it lead to more people being diagnosed? Is this a good thing or a problematic thing? And I think the key thing is that if a person has these patterns and they're causing them trouble and they're not being recognised, certainly this was my issue with young people, is that they were not getting access. People weren't thinking about that side of the problem and getting them access to treatments that might really help. And so I think the key thing is it's only worth doing diagnosis if actually it leads to meaningful change for a person. So I would hate to see more like, okay, more labeling of people without any meaningful change there. And at the same time, we do want to increase the awareness of these issues in non-specialist and other settings. So I think there's a delicate balance there. Is the severity indicator a quantitative description of the borderline trait qualifier? I would say yes, is that people who typically get that label now would meet criteria for moderate to severe personality disorder with negative affectivity and possibly disinhibition, and maybe some people might have dissociality depending on the particular way in which they present. We've talked about the ADHD, and it's the same thing there. You would only give personality disorder in addition if that was meaningful in some way. Yeah, and I totally agree that it doesn't feel right that a person attracts a diagnosis to get treatment. And so I certainly hope we would hope that was not the case here. But there are some places in the world, Germany, for example, you wouldn't get treatment unless you had the diagnosis. Yeah, okay, I'm going to stop talking now.
Thanks. That was fantastic. There's so much information, two really substantial, very interesting presentations that I think we had something like 260 people during the webinar. The video will be available on YouTube, so anyone else that's missed it, any colleagues that have maybe not been able to attend today, will be able to view on YouTube. There's been a number of questions around about mailing lists and letting people know about future events. We'll absolutely do that. If people want to be put in a database, please comment in the chat or contact via our team email address. We can do that. There's a couple of things that have been raised today that we're going to look at more detail in our next learning system event, which is a workshop. So some questions around about that. That will be a more interactive format. It'll be a bit longer format because there's lots to talk about. And I think once we get into it, I mean, I think we could probably talk for another hour here. But so we're going to look at the The workshop's going to be entitled The Challenges of Diagnosis, and we're going to hear from colleagues in NHS Highland who have been piloting ICD-11 since January. So we'll hear a bit about the practical experience with some breakout opportunities and to have some further discussions there. And also we're going to hear from Professor Thanos from the River Centre in NHS Lothian, round about a bit more round about the detail of that kind of the distinctiveness between the diagnosis of complex trauma and personality disorder. And there are many more events to come in our learning system. So please, if anyone's interested, keep an eye on the social media and your mailing list. Final thing is just to thank John and Michaela again for joining us and giving such fantastical interest in presentations. Thank you very much.
Pleasure.